My name is Vincent Amazona. I am the specialized trainer here at Care Indeed, one of the nurse advisors, Heidi being one of my great counterparts. Um, let's see, let me unmute my video. Oh, there we go. Hi, everyone. so, um, yeah, feel free to unmute and talk. We're going to have a bit of an intimate gathering today, but that means an opportunity to ask more and more questions that you feel may be prevalent to working with people a cerebral palsy. Maria or Heidi, have you guys worked with, or do you have anyone currently on your rotation that you work with that has cerebral palsy? No? Okay. Well, it is a
I
very
did.
unique disease. I'm
I
sorry?
did Vince for
Oh,
like
okay.
5 years, yeah.
Oh, what was your experience with it?
Actually, it's quite challenging,
Mm-hmm.
especially he's like, from neck down, he is paralyzed.
Oh, okay.
Yeah, so it was challenging, but it's a lot of, learning curve there.
Yeah. And, being in healthcare, you're going to come across a lot of different issues with people. Some of them seem very unique to one another, but um, usually when they're in the realm of the same disease or issue, um, it comes down to personality type and things of that nature, just like the way you were raised. So let's go ahead and get into our project today. Um, so for the past year, I've been using PowerPoint as a jump off point for education and for staff development. I'm happy to introduce today that we're getting into Adobe Captivate, which is a far more intuitive and modular learning experience for our learners. It allows me to create projects that are far more interactive than just me reading PowerPoint, which, as entertaining as that may sound, yeah, I'm sure it gets pretty tedious. That being said, we are going to produce these programs through Adobe Captivate as we try and make our staff development a little bit more reinforced. We'll be putting together courses that assist with specialized care, basic care, and any soft skills that may be necessary for our caregivers and our staff. So let's go ahead and jump right into that. Today's presentation is going to be cerebral palsy and the role of the caregiver. Now, like I said, I'm the specialized trainer. So some of the courses that I go over here are really about specific plans of care. We all know that we help with the aging and people who have specific changes of condition or within a certain age group. However, when you get to certain diseases, the hallmark diseases that may be a little bit more challenging for our clients or for our loved ones, we want to make sure that we're addressing everything that they need given the progression of the disease. So for this module, my goal is to make sure that we can discuss types of different cerebral palsy, the disease progression of cerebral palsy. I want to be able to make sure that you guys identify the precautions necessary for this specialized plan of care. And we're going to go ahead and you should be able to discuss what your role as the caregiver for those living with cerebral palsy. So the disease progression of cerebral palsy is very unique in that it's not an age-related disease in much like Alzheimer's or Parkinson's. There is no major life change of condition that can occur in which all of a sudden someone is diagnosed with cerebral palsy. It strikes as a malformation during birth. It's a developmental disease. Much like Alzheimer's and much like Parkinson's, it affects the brain. So abnormalities in the brain either hinder or slow down the development, and also a musculoskeletal issue as well as a nerve issue that prevent the brain from communicating with the muscles as through the nerves. So if you imagine like a computer or like an Apple TV, the brain would be the Apple TV, the TV would be the nerves, your enjoyment would be um, the musculature of your body. If one of those isn't communicating with the other, or the pathway to communicate from the brain to the muscles is damaged or obstructed, then the signal doesn't go through. Much in this way for kids, typically diagnosis happens within 12 to 18 months. They identify cerebral palsy as being the condition that this person is living with. Now, there are risk factors. In some cases, it's genetic. In some cases, it is just a birth defect due to, uh, I'm sorry, it's a birth defect that occurs, again, due to certain risk factors during pregnancy. So we're going to go ahead and click forward to that. There are four main types of cerebral palsy, but all of them are based off of occurrence of different symptoms or different issues that happen to the body that come together to form what cerebral palsy is considered. It is first and foremost a motor control disorder caused by injury or abnormalities in an immature brain. Immature brain meaning one that hasn't fully developed yet. So this is where it goes back to either a birth defect or early childhood. This is a permanent disorder that is non-progressing, meaning it doesn't get necessarily worse. The way when it occurs, that's exactly how it goes, and occurs during fetal or infant brain development. The motor disorders can include sensory perception. So any of your five senses are going to be either hindered or non-present, meaning they could work, like you could, technically the nerves are there in your hands to feel touch. However, the signal's not getting to the brain, or the brain isn't recognizing that signal. So it doesn't necessarily know exactly what to say. Perception, the way you have that feeling of what's around you, but also your sensory perception. That means depth perception, your eyes aren't fully developed, or again, there's a lack of communication and understanding between the systems and the brain. Cognition and behavioral. Again, so these go towards the idea of an immature brain or an abnormal brain. Cognition means you're not recognizing certain aspects of communication or people or feeling or emotion. And as such, behavioral gets affected as well. Sometimes it's a heightened aggression. Sometimes it's a lack of aggression at all. So a flat affect, or just a very plain apathetic demeanor. Musculoskeletal seizures and epilepsy. That breaks down to how the brain and the nerves are firing in order to control or lack of control for the muscles throughout the body. Musculoskeletal meaning any random muscles, but it's more prevalent in the extremities simply because it's very hard to detect muscular issues in the core of the body, as we see in the center part. Seizures and epilepsy. Epilepsy is marked by 2 recorded seizures within a certain period of time. So automatically, it would either be diagnosed as a seizure disorder or a full-on epilepsy. Abnormal muscle tone and coordination are the primary problems seen. Again, if the muscles don't know what their stasis is, they can't grow or be developed simply because they're not being moved or have lack of movement. The coordination, that goes back to the communication signal between the brain, the nerves, and the muscles. Again, any type of muscle, involuntary muscle, voluntary muscle, things that I can command, things that I cannot command, that your body is constantly doing without your knowledge, are affected. Sometimes there are heart disorders, sometimes there are breathing disorders. Those are things that you don't tell yourself every day. You don't tell yourself to breathe, breathe, breathe constantly to keep yourself alive. Some other involuntary muscles are that in the digestive tract. So that means sometimes food does not get broken down properly, or the involuntary muscles and the signals involved with urination, bowel movements are not controllable, or the sensory feeling is not there, the urgency to go. So there will be a lack of bowel control. In and of itself, as a seasoned caregiver or working in healthcare, you're already going to identify certain aspects of care for this when you're building that, when you're given a specialized plan of care. Can anyone really identify, just based off of these 4 factors, what you could see as possible issues? So yeah, behavioral issues. We're going to talk about behavioral management, slurred speech. That could also mean a lack of control or motor control or sensation within the mouth. So speech pathologists are not only brought in to help speak, but also help people understand how their swallowing goes, the top part of the digestive tract. Lack of muscle control, meaning if they are not paralyzed in any or all of their extremities, such as their legs or their arms, they may have gait issues. And lack of bowel control, we're talking about incontinence.
Vince,
Yes.
can I ask question or later?
Oh, no, go ahead. Let's ask questions. This is free reign, guys.
Okay, so just for the lack of muscle control, so I know there's severity of, with when it comes to their muscle control problems. Will physical therapy help as well, or will it improve when it comes to, with that issue?
So, as muscles tend to not develop, range of motion goes down, right? But you have to keep it going. So, physical therapy is involved. There are activities that are built around at a pediatric level for a lot of our CP sufferers. What that means for the adult with
Yeah,
CP
the adult. Yeah.
is that as you get older, into your 40s and 50s, you start losing muscle tone. So that's when physical therapy becomes less more of developmental in order to maintain strength, but also it's to maintain tonicity of the muscle and aid in range of motion. So physical therapy becomes a very important and routine aspect of it. So one thing you're going to have to understand in a specialized plan of care for CP is range of motion exercises will be dictated, hopefully implemented, um, as well as daily activities. We try to make sure that we're engaging the person on those activities that are both mental and physically stimulating. Um,
Thank you.
is that okay? So
Thank you.
yeah, so spastic cerebral palsy is the main type of cerebral palsy. Spastic CP is common. People will experience increased muscle tone, and their movements may appear stiff or awkward. Now, spasticity refers to that constant idea. Instead of a flaccid or a limp type of muscle tone, we are talking more along the lines of a stiffer or more contracted muscle tone. So if the brain doesn't tell the muscles to fire, in some cases, they're not being engaged. In some cases, the brain is constantly engaging the muscle to contract, right? There's 2 states for muscles. It's either it's relaxed or contracted. If it's constantly contracted, then the buildup and the automatic use of that muscle means there's increased muscle tone because it's always flexed. Um, but as it gets older, it becomes more locked into place. So you'll have a hand that may have some sort of motion to it, and then the brain starts to fire abnormally, and it starts to contract, and then the range of motion goes. So it's no longer relaxing anymore. It's constantly staying in a constant state of. It's constantly staying in a state of contraction. So stiff and awkwardness, because if they have other muscles that are working normally, if a muscle group, muscles work in groups. If one muscle is not properly firing or being engaged, it affects the whole mechanism of movement. So the other 4 types of CP So on the opposite of kinetic or spastic cerebral palsy is dyskinetic. So that means if you look at this figure here, um, it talks about the different uses of on your body of what CP avails you as it affects your brain and your muscles. So dyskinetic motor patterns are characterized by slow and uncontrollable writhing or jerky movements of the hands, feet, arms, or legs. Have you? I'm sure some of you have worked with Parkinson's clients before. One of the early signs of Parkinson's, although not necessarily the hallmark, is that tremor, right? It kind of shakes. That's involuntary. Sometimes uh, it can be shut off by giving the person a pen, and automatically they're focused on gripping it, so the tremor goes away. For cerebral palsy, that writhing and jerking is much the same. However, it's not limited to the hands. Um, there's also ataxic cerebral palsy, which affects balance and depth perception. So that's more towards the vision aspect of it. If you don't have stereoscopic vision, the idea of being able to grab something out in front of you, you can't measure specifically, which is one thing we all really take for granted. I mean, even if you're trying to touch your phone, you don't know how far it is, or you can gauge physically by how far apart it is from your hands. But looking at it directly in front of you, you may be whiffing at it. That's a simplified version of it. So again, as this is a developmental disease, children with ataxia will often have poor coordination and walk unsteadily with a wide-based gait. Um, so that's a natural occurrence in response to not having the best balance is you try to create a wide base, right? If you ever find yourself waking up at night and going through the dark, you tend to have a wide base, or if you feel a little dizzy coming off of a roller coaster or just having been turned around a lot, um, then yes, you try to make yourself a little bit wider at the legs, so more of a pyramid stance. And so that's to prevent falls. That's the brain telling the body this is the best way for us to keep standing. And then, much like Alzheimer's, we have mixed types. So, mixed types of CP refer to symptoms that don't correspond to any single type of CP, but are a mix of types. So, different issues that are developmental manifest themselves into something that is along the lines of cerebral palsy. For example, a child with mixed CP may have some muscles that are too tight and others that are too relaxed. So then others will be working properly or on the side of contractures, while others can't be engaged and have a very loose muscle tone. So over here in this figure, we are talking about spastic hemiplegia or hemiparesis. That means one side. Hemiparesis, hemi meaning side, like hemisphere. Those are you'll find that from the head down, those muscles are being affected. Most likely because one side of the brain, like the left side of your brain, tends to affect the right side of your body and vice versa. So you'll find that due to that lack of development, one side of the body can't be engaged. Again, uh, given the certain aspect of the brain development for here, spastic diplegia. So the body's intersection is now across the waist. They may be paralyzed from the waist down. And then spastic quadriplegia or quadriparesis, meaning all four extremities, including the head and neck, cannot be engaged or have no feeling. So we'll just let this part play out. Any questions on that aspect of the disease process? This is still running.
None for me so far.
All right. So we talked about it being a developmental disease. And so given the fact that we deal primarily with clients of age, it's best to understand that the majority of individuals with CP experience some form of premature aging by the time they reach their 40s due to extra stress and strain the disability puts upon their bodies. What they mean by strain is constantly having to balance themselves, muscle engagement, involuntary movement. Having a movement that you cannot control that's in a large muscle group really taxes your body. Just imagine having to like do this or constantly flail. Those things are very taxing on the body as they get older. Um, a lot of times, the stress and anxiety that one person may feel from not having control of their body, not having the ability to communicate with themselves or to others, can lead to frustration. In my PEDS rotations, I've seen that a lot, and there are kids, having in childhood that you'll see parents tell their kids, use your words when the kids lash out. Kids lash out simply due to frustration. Now, as an adult, that becomes the only um, means of letting others know that something's not right. It may very well not be something specific, but they can tell at a basic level, this is good for me, this is not good for me. This is what I like, this is what I don't like. So a lot of times when I talk to caregivers, for those people who have low communication skills, you have to really pay attention to non-verbal cues, right? Um, Nonverbal cues for a lot of the people who have no communication skills or communication abilities are very key. Um, and you'll see some of the best caregivers, the ones that really pay attention to the details, or the ones that have had the most experience with their clients. They definitely understand what a motion or what a grunt or what a sound sounds like, and how it denotes to that person that they're helping. So pay attention to those. The developmental delays that often accompany CP keep some organ systems from developing to their full capacity and level of performance. So that means they may have an underdeveloped heart, underdeveloped lungs, because it's a child's. It's part of human development that the more active you are as a child, it pushes the maximize. It helps maximize your lungs and your heart capacity. Vasculature, meaning your veins and your arteries, may not circulate as well if they haven't been used that much, or uh, even digestive issues. If someone is born with the inability to swallow or to chew, the type of food that they go into really affects how often that digestive tract is used, how often your stomach is used, how it's formed or conditioned to produce certain types of bowel movements. Are all things that, if not properly uh, utilized, as in a person without CP, a person with CP is going to face those hindrances. So as a consequence, organ systems such as the cardiovascular system, hearts, veins, and arteries, and pulmonary system, lungs, have to work harder, and they end up aging prematurely. Those are the basic life. Those are the basic life systems, right? And if that's all they have to keep pumping blood. They have to keep taxing themselves to a body that may not be able to circulate properly. Um, that becomes an issue. So let's do this knowledge check, everybody. Um, Quick one, cerebral palsy is a contagious disease like HIV or measles. Hand up if you think it's true. Okay, Maria got it right. Anybody else?
Me, it's non-contagious, so it's false.
Non-contagious.
False. It's false.
So let's go with false. So that let us continue, and that means we're good to go. Okay, so now you know the disease, you know the disease process, and you know how it affects adults. Given the aspects of cerebral palsy and how it affects people, we as caregivers have to address or enact precautions for our clients. Uh, as many as half of all people with CP have had one or more seizures. Most of these affect childhood, in fact. For me personally, one of the most frightening or stressful things I've experienced is watching a child have a seizure. Some parents are very keen to that and they've lived with it, but for me, it's very disconcerting. Um, but yeah, those with both cerebral palsy and epilepsy are more likely to have an intellectual disability. So again, that goes back to the development of the brain. Um, if your client has epilepsy or another condition that causes seizures, the healthcare team is going to develop an appropriate treatment plan. Automatically, you should know that those are seizure precautions, but those can also entail med management or med assistance when it comes to the client. Because when you take seizure medication, it has to be very precise. The timing of it has to be precise. For nurses, you're typically given an hour ahead or an hour after in order to make sure that all medications are passed accordingly. For seizure medications, it is best to never deviate towards too early or too late. If the medication overlaps, so in my blood, I have this amount of system and it's supposed to taper off, and then the next dose comes in order to maintain that level. If there's an overlap and it ends up shooting up, or you're running late and it underdevelops, the blood level's off. So side effects and the main course of action on the body end up being more severe. If it's an anti-seizure medication, the muscle engagement goes down. If the medication is too much in the blood level. So it's important to lower the risk of injury during a seizure. That's, as a caregiver, your goal here is safety. So take steps to minimize hazards such as glass and sources of heat that the person is engaging in. I point those two out simply because you don't know how often someone's always holding something that's glass, or how often there's something around you that's glass. Those end up being or shatterables. Things like plates, those things that can end up coming apart, breaking, and forming very sharp edges. Sources of heat, that does go for electricity for me as well. But sometimes you want to engage your client and they want to help cook, right? So sources of heat, and that takes place in the home, in your place of work, wherever they're exercising, and especially outer environments. When you are able to take your client or your loved one out into social environments or even for walks, you really have to become more mindful of the surrounding environment. And you kind of dictate how the day goes with that, how that activity will go. Is that too much of a slope to carry? Is that too much? Is that too many stairs, given how fast my client walks and their ambulatory issues? Is sitting on that surface low enough or high enough so that way it may not be an issue? If they're sitting up too high, end up having a seizure, that presents a fall. Because remember, you have to help them to the ground when they're going through their seizure. Too low, they may not be able to get up, and then the stress and the exertion may induce one of those as well. So as a caregiver, let supervisors, other staff, and trusted peers for the family know about that condition. Your role will be to adjust daily habits as needed to keep the person safe. So for those of you that aren't familiar with seizure precautions, basically, well, who set the time up? Basically, so for those, there we go. Seizure first aid, how we're gonna help someone having a seizure. So number one, you need to stay with the person until they are awake and alert after the seizure. As a caregiver, the first thing you do after you make sure that they're safe is time the seizure. Get an idea of what time it occurred. So that way you can report to first responders or to the family or to the other parts of the healthcare team how long the seizure happened. Number two, remain calm. That for some is very instinctive. You see something go sideways, automatically there's a level of calm that waves over some people. It's very special talent that people do have when they can remain calm in the face of crisis. And then check for medical ID. If you don't know this person, it may state who to call or what their issue is, so you can report that as well to 911 should you have to call. Number two, keep the person safe. Move or guide away from harm. So if they're rolling around uncontrollably or flailing around, you don't want them near water, you don't want them near edges, you don't want them on an uneven surface. Number three, we want to make sure that you turn the person onto their side if they are not awake and aware. That's to help keep the airway clear. So if you lay down on your side, your tongue tends to fall towards into one cheek instead of folding backwards, or kind of like lapsing back and then covering your airway. Any tight clothes they may have around their neck, make sure it's loose. Collars especially, because those could snag on something or they could end up pulling at it. Put something small and soft under the head. So a little pillow. If you have a sweater, just throw it under their head and their neck, because you don't know if that seizure is going to end up making them buckle backwards. Understand that when the body contracts, it can fire. All the muscles can fire all at the same time, and that makes someone very, very stiff. And the force in which it happens can actually hurt somebody if you're not careful. And for those with seizure disorder, there are certain times where you won't have to call 911. But under these conditions, call 911 if the seizure lasts longer than 5 minutes. That goes back to step one, where you time the start of the seizure. Number two, the person does not return to their usual state. Again, if they were talking and before the seizure happened and they are no longer conversant, that's usually a sign that you should call back or call 911. If the person gets injured, pregnant, if the person is injured, pregnant, or sick. I don't think anyone's ever gotten pregnant from a seizure. So if the person is injured, already pregnant, or sick, okay? And if they've had repeated seizures in that duration of time, if this is the first time that they've had a seizure, if they develop difficulty breathing, or if the seizure occurs in water, simply because the involuntary gasping could also lead to swallowing or aspiration in the lungs. The two do not. And you see some of this in the movies, and the movies sometimes, I mean, if you work in healthcare, you've seen movie dramatizations, and they're the worst. Yeah, never restrain someone who's having a seizure. Again, contractures, those are the muscles pulling back in a very stiff and violent manner. Those could happen during seizures. If you tried to hold a hand down and it will contract, you will end up snapping tendons, either your own or the person's. But my concern is the person's at this point. But yeah, both of you need to be safe. And don't put any objects in their mouth. I think that was actually something that they used to do a long time ago to prevent people crushing their teeth or biting through their tongue. That is not as prevalent as much. Another thing is for you as the responder, if you're trying to put something in someone's mouth, if you can do it accurately, I mean, kudos to you, but still don't. But if they're moving around and you're trying to push it and there's something in your hand, it could get lodged back in their throat. Secondary, if they end up clenching their teeth, you could end up getting bitten, and severely, because again, these are strong contractures. Any questions on seizure first aid?
Vince, I'm not sure if you mentioned, or I wasn't able to listen to it. So as a caregiver, so for example, I know that my client has a seizure, and of course you can't predict when it's gonna happen, right? Will it give me somehow like some signs or clues that he or she's about to experience a seizure? For example, she's able to verbalize how she feels. Is that like something that I need to kind of like be aware of?
So again, if they have a diagnosis of epilepsy, the healthcare team kind of monitors that, and so they'll be able to tell you how they get. One of my former clients, she would complain of massive headaches prior to that, much like an extended migraine, which isn't natural for someone of her age. So her time was, if she complained of headaches, they would automatically put this child in some sort of not isolation, but sensory deprivation, things that would trigger headaches, such as bright lights, sounds, overexertion, and let her lay down with a pillow on her head. Now they've covered two things. They're trying to address the headache, what triggers it, hopefully stemming the tide of that potential tremor coming or that potential seizure coming. But also, should she go into one, she is away from certain things, she is already on the ground, and she has a pillow under her head. So those things, again, yeah, when you come into a plan of care or to a new client, those types of things have been established for the most part, unless it's a recent occurrence, which is going back to seizure first aid. Understand that this is your goal. This is your automatic go-to, is the person's safety. It's not up to you to have to worry about whether or not they're having seizure. Just identify when they are. Again, if they act abnormally from what you've seen in the limited time that you've seen them, it is way better to err on the side of safety than to just assume that it's something that it's not. I would rather you overcompensate than underdeliver, basically.
Okay, thank you.
Okay, so again, we're going the second aspect. Lack of communication, lack of involuntary muscle control, lack of coordination, aspiration precautions become very serious. You'll see that some people living with CP have abnormalities in their mouth, also in their ability to chew and swallow. So they may be on specific diets, consistency diets, meaning they can't eat certain things of a certain thickness. They can't eat certain types of meat. And even the liquids they drink can't be a certain thickness. So it can't be like water thin. It can be something a little bit thicker, like a nectar or specific types of juices. So as a caregiver, someone who is on aspiration precautions, just let me get into it really fast here, is if you can see my mouse, yeah, my mouse, not my mouth, but as something enters the mouth here, it goes past the teeth, the tongue chews it, and then I'm sure everyone's had done this when drinking something fast or eating something or talking at the same time. You get that pain goes in the throat and you start coughing. Everybody asks you what's going on, and you say it went down the wrong pipe. So at this point in the body, it's going to go to two different pipes. One of them goes to the lungs, and the other one goes straight to the stomach. When you don't have muscle control, this whole mechanism here, the chewing, the tongue, and the swallowing, are all coordinated, right? That's what we call a gag reflex. If you don't have that sensation, if the brain's not signaling that aspect to your mouth, this bit of, I'm just going to say strawberry because it looks like a strawberry, could get swallowed and passed down. And if this aspect of muscle control is not coordinated, automatically something happens that could be detrimental or bad for the person. This may not, the tongue and the palate may not sense that this has been chewed properly and automatically swallowed whole. It could be chewed and sent down the wrong pipe automatically with no feeling, which means the lungs could fill up with a foreign body that's not supposed to be there. Fluids, automatic fluid buildup in the lungs is pneumonia. They have this condition called aspiration pneumonia, where liquids kept on going down the wrong pipe. Or in some cases, someone has had an episode of vomiting. So the vomiting comes up from the stomach, right? Doesn't make it outside, comes up, maybe gets up to this point, automatically the nerves here kick in and they do one job, right? Swallows it back down here. So that's what typically happens. This is one of the reasons why we have to, when someone's vomiting, we try to make sure that they're staying safe. You as a caregiver, if you understand that they have aspiration precautions, this is what you do during and after meals. Aggressive oral care before and after meals. Make sure that their mouth is clean. That's your chance to make sure there's no foreign objects, leftover food, unchewed food, which may be an issue. Things that get stuck in the gums, between the lips. All of that needs to be addressed. So you do it before and you do it after. Make sure that the person is sitting up at a 90-degree angle in bed or chair for meals, or follow the specific positioning guidelines per their speech language pathologist. And they have to stay in that position for up to 30 minutes after the meal. Again, this is someone whose muscle tone may not be as strong, or it may not be as engaged. All of this, from the moment you swallow something like this, there is a involuntary motion called peristalsis, which means it takes this bolus of food or a little bit of food, and automatically these muscles go into a wave-like motion, and it rolls it down. So if they don't have that, or if that's miscoordinated due to abnormalities, then it's going to be slower for them to swallow certain foods. So you want to make sure that there's a chance that it's not still here and gets put down the wrong pipe or gets lodged in here. So we want to stay up. We want to work with gravity. Gravity is going to assist this going downward. In a person without these issues, you could technically stand upside down, eat a piece of apple, and you could feel the muscles working against gravity. That's how strong they are. But if you don't have that, we want to assist our clients, make sure that they have the chance to swallow it. So we use gravity. And then 45-degree angle at all other times. We want to make sure that they're in a sort of Fowler's position, which means mid-bed, right? Not low bed, not high bed, low Fowler's position. So that way, if they have secretions, because remember, drooling is also an issue that you may have with someone with CP. They don't have the swallow, the strong swallow aspect. So they may be developing that spit or that drool, and they could swallow it. So you want to make sure you're working with gravity. Some clients are going to have suction that may not go into your role. So, but if you identify that it's there, you use that as a signal that this person may have swallowing issues. Monitor any lung sounds, temperatures, especially after meals. Lung sounds could be a sign of distress if they're abnormally breathing from when the meal happened before, or from before the meal. There's a sign that something may be off. You may hear gurgling. You may hear labored breathing. It may become high-pitched because something is stuck in the windpipe. And then monitor intake and offer supplements or between meal snacks as needed. Because when someone has swallow issues and you're putting them on aspiration precautions, you are going to be assisting them to eat at a slow pace with a very small portion. And that can take a long sort of time. Given the fact that this person may be hungry, they're still receiving the nourishment they need, they could also grow fatigued from this activity. Now, if they don't want to eat their lunch later on down the line, it's best not to try that, but you can offer more snacks in between the meals to keep them full. It's best to do that rather than trying to clear a plate and feed all of it to them. That's not the goal. The goal is to make sure that the person is satisfied, but do so safely considering their precautions. Any questions regarding aspiration precautions? Okay. I guess one thing I wanted to touch on is you'll also see certain types of liquids, nectar thickened liquids, or there are liquid thickeners, or liquid thickeners that are powders. Sorry if that's confusing, but powdered thickeners. There we go. And you add to those. They're not uniform. One thing I've noticed is a lot of people treat them all uniform. Some of them come in a big jar. Some of them come very small. That's not like a Coca-Cola. There's a reason why the concentration is that short, right? So 2 scoops of the small one is not always 2 scoops of the big one. So always read the label on it. And if it doesn't have a label, don't touch it. Tell somebody. Those things do tend to wipe off, but it's better to be safe than sorry in this case. So fall precautions. We talked about clients with CP that have a wide-based gait. Those are the ones who are fortunate to be able to have a level of mobility. So those, we want to make sure we're addressing fall precautions. This is one of the basics. We can get through this one. Definitely want to readdress it and reinforce things that you need to know. Around the home and the environment care, making sure that we're cleaning up clutter, repair or removing tripping hazards. A lot of times people assume that it's for the client entirely. If you're helping to push someone or transferring them around the house, you'll see rugs, you'll see cords in the middle or by the bedside. If you have to develop a wide base in order to transfer somebody, I want you to make sure that you're addressing those tripping hazards for your safety as well. Because you will be transferring someone, their weight will be reliant on you. And if you get taken out by a rug, now it's not just your body going down, it's your body plus somebody else going down on top of you. So that's a big issue. So tripping hazards, those aren't just for you, or those aren't just for the clients. They are for everyone that's in that home environment or that care environment. Make sure grab bars and handrails are installed. When our staff does an assessment, they'll be able to address that for you. If you see something that doesn't seem safe, by all means, report that as well. Avoid wearing loose clothing. That's more for the client. Tripping hazards, if their pants aren't cuffed properly or they drag, those loose clothing. Loose socks are also another one. Loose socks tend to snag on things. Some of our clients, they have had very loyal socks that they've kept forever, and the elastic ends up blowing out. But they love that sock. You're gonna have to either throw it in the back of the cabinet or the drawer so it doesn't appear in the rotation as often. But you want to address the proper footwear. Light it right. Make sure that the environment is always well lit. A lot of the homes that we'll see, they were older, so they didn't have like light switches or like ceiling lights. They're basically a lot of lamps, mood lighting, and natural light. Try to maximize the light that's there for you. It's also, again, for you in the role of the caregiver to address being safe in a safe working environment. Wear shoes. As the person who has a history of falls, make sure you're wearing shoes. It's better off to wear shoes that are properly fitting and have traction, or even the non-slip socks. Here, we're talking about making it non-slip. That also goes for showering surfaces or any transitional surfaces. You'll see a lot of homes that have wheelchair grades that are for maybe somebody else, but that's the main step, and they choose to walk on those without the traction of a wheelchair. So there should be a level of grippy surface to it, especially on the steps, and keep it on the level if possible. Keep the continuum of care on the same level of the home. Try to do all the activities, all of the daily things, keep them all on the same level throughout the day. Having to transfer someone up and down throughout the day sort of increases the liability of things. Okay. And I hit the fast forward button again. All right. So another knowledge check here. So we're going to match the issue with the type of precaution that we'd be looking out for. Let's just go ahead and get this one. Unsteady gait, what's the type of precaution you guys see? A, B, or C? Correct. It is B. Weak swallowing, is that a seizure precaution or an aspiration precaution? I see you mouthing it, Maria. You're right. Aspiration precaution. And that by process of elimination, history of epilepsy will be seizures. Yay, we're able to move on. So we're going to talk about transfers. I know I've kept you guys a little bit longer, but we did start a little bit late, so we'll be okay. You'll see here, either a physical therapist friend of mine pointed this out. This set of slides, if you look at it left to right, she's helping someone move backwards, right? If you're looking at it from right to left, this person is being prepared to be moved forward, right? Same motion. The weight transfer is pointed out here in all of the bars and dots. The weights should be here on the person's foot starting, and they should have a solid base. Their weight is going to move directly into your weight, right? So that way it's not a lifting motion, everybody. It is not. It is about getting that person's weight to move towards you. And then right here, using a gait belt or a lap belt, the exertional force, when they move forward, they end up standing up. And then again, the wide base you're trying to establish when they've transferred to it. Let's go into transfers. Where are my transfers? There we go. So when we're trying to transfer somebody, some of the basics, we want to make sure that we're keeping the person close to you, right? So that way the weight isn't suspended. It's not separate. You guys are going to move as one, right? Instead of one person pushing on the other. Keep the person facing you. Your knees always need to be bent. We're going to always use your leg muscles instead of your back muscles. Legs are the super strongest part of your body. When you want to work out your legs, never skip leg day sort of thing. Keep a straight, neutral spine. Don't curve it. So if this was my waist, this is your neutral spine, straight. We don't want, if this is my waist, we don't want you to arch like that, right? Because now you're folding it. You folded yourself. Your shoulders are folding over, and that's going to actually put strain here on your abdomen. This is your spine pulling down, and then you're going to try to like that, and then that's not right. So neutral spine, flat as a board. So that way, when you pull, your leg muscles down here are pulling your back up straight. And make sure you place your shoulders, your feet shoulder width apart. Shoulder width apart is the athletic pose. It's the solid pose. People in football or in other sports, if they get hit, it's when they get really toppled over, it's when their base is low, because then your shoulders are out farther, you're top heavy. If you make yourself into a pyramid, you can't knock it over. There's a reason why the Eiffel Tower is built like that. There's a reason why the pyramids are like that. They've stood the test of time simply because of that. The Leaning Tower of Pisa is thin, and it was also built on a thing, but it becomes more prone to toppling. Keep your heels firmly planted to the ground. The reason for that is if, again, you want to be able to push through your legs using your leg muscles, pushing through your heels is the best way to go. Pushing through your toes doesn't necessarily push you upward. It can push you forward, especially if the weight's leaning. So keeping an idea in your head that I need to stay on my heels and push up or take their weight means the exertional force goes down into the ground. So you're pushing down into the ground, creating a counteractive force of the person's weight. Consider the patient's or the client's weight and assistance level needed. Never attempt more than you can handle. Now, this becomes a very contentious situation because we work in healthcare teams. Talent, knowledge, and level of stress, anxiety, a lot of these things that when it comes to care become subjective, just like the idea of care itself. What one person's level of care may not always be someone else's level of care. But we try to hold ourselves to a standard. The one thing that doesn't change across multiple care teams or care teams with multiple people is the client. If they are able to assist, that's going to be established. Their weight may fluctuate, but that's always going to be established. Never attempt more than you can handle. If you cannot handle that weight and you've tried in earnest, it's best to say something, because you may be better served helping somebody else. And the last thing we want to do here is get you hurt. So there's not a point of pride in trying to say, well, I've seen, and I've seen it before, you'll see the smallest caregivers with the most experience lift someone my size. Sometimes it's more about economy of movement. They know how to handle the weight. They know how to handle how they move about things in a safe manner. You may not be at that level yet, but to try to practice on somebody in a situation that's going to constantly put you in danger 2 or 3 times a shift, that's gambling with your career. So again, all these things are subjective. And the last thing a family needs to see is, while your heart is in the right place to help their loved one, to see you struggling, because remember, that's their loved one, that's their family member. That someone who is like shaking and getting frustrated, they don't need to see that. It's not a good look for you as a caregiver. Yes, you may have helped other people transfer and assist in a similar situation, but everybody's different, right? There's 2 variables coming together. It just may not be a match. To say, oh, well, they're not helping, or, well, this person is not like this, it's kind of dismissive to the person that you're trying to help. They may be willing to engage as much as possible, but to say, well, they're not helping, is dismissive of all of what they can do. You're focusing on their limitations rather than their opportunities. And we don't want to do that. So I try to stress for everybody, be honest with yourself. While this may not be where your focus of care is better used, safety is paramount, and you could definitely take your brand of safety, your brand of care, to somebody else, and it could help them way more. So take those things into consideration when you're helping people. Enough of that. Avoid twisting and rotating your trunk. So that means try not to jerk yourself side to side like that. You're trying to pivot off of the feet, because your back is very important to you. Avoid combining movements, such as rotating and bending at the same time. So that's like bending over and a rotation, and then just try to carry them all in one fell swoop. That is a key to disaster, especially if that person doesn't want to be moved like that. They could bail out in the middle of this complex motion, and now you don't have a place to put them or a place to set them down. And that place to set them down will be on the floor. So not to be confused with trying to do it in one fluid motion and moving with purpose, but never combine the movements. Another reason for that is, when you are guiding somebody, you will be talking to them as well. You'll be talking to them and letting them know, okay, this is what we're going to do. So you're breaking it down into steps. While they may not be able to communicate, they may be able to understand in little pieces of what to do, of what you are going to be doing, and they develop trust in you at that point. And where are we here? Oh yeah. So cover transfers, and there are other issues that are involved with the client that come with CP. Contractures. We talked about contractures. Yeah. Oh, here we go. Sorry. So contractures. That's when the muscles can become painfully fixed into abnormal positions, called contractures, which can increase muscle spasticity and joint deformities in people with CP. You may have seen it. There are some people who have had cardiovascular issues, such as a stroke. They no longer have the use of one side of their hand, and the hand ends up becoming withered and controlled like that. 2 things. When you are working with them, it can be very painful to try to open those things up. So it's a very slow process that you have to pay attention to nonverbal cues of pain. Secondly, when someone does have contractures, as a caregiver, in terms of hygiene, in terms of dignity, people don't pay enough attention to 2 things. like a hand, if it's contracted, or an elbow or a thigh. I don't see enough people, and I'm not naming anybody, but from my experience, I never see enough people working to clean the inside of those contractures. I've seen a lot of people who have had strokes and end up with those contractures. While they can't move it, nail and bone growth is still going on. So on occasion, I've seen people and worked with them to open up their contractures for physical therapy or try to get a brace into their hand. And this whole part here is dirty and dirty skin, dead skin, mottled skin because it's been sweaty, it's been wet, and it's been broken down, open to infection. The second part is while that skin never sees the light of day, or like for some people, if you've worn a watch, right, and you take that watch off, the skin is completely different than what's being exposed. Imagine that, but because of the contracture. So it's not being washed. You could run like a small soft cloth through it with soap and water. The second one that you're going to run through is also a dry cloth because you never want to leave these skin wet because it could become mushy. Another thing is nail care, because people don't pay attention to the nails that are always contracted. Those nails are still growing. So more often than not, I've seen people when the physical therapist has gotten it opened, these nails have curled over into the skin. And they'll say, why is there skin under their nails? That's old skin that's been dug into over time from the nails that are growing. It may not be your role of care to take care of this person's nails, but at the same time, you have to be able to observe it and report it to the rest of the healthcare team so they can find a specialist who will be able to cut their nails or file them down at least, or find a proper brace for contractures. Malnutrition is another issue that that may not be fully prevalent, but also something that you should pay attention to. Swallowing, sucking, or feeding difficulties can make it difficult for many individuals with CP, especially children and infants, to get proper nutrition and gain or maintain weight. That's a simple fact. Intake is not nourishing them, they're not getting the right nutrients, and their body ends up wasting away. So pay attention to the weight logs. Pay attention to if you have that eye, if you could tell someone's just kind of losing weight, their skin becomes a little bit more hanging, or they become a little bit more lean in the jaw or sharp. Pay attention to that. Pay attention and report and observe how much of each meal that person's completing. You have the time to measure out the person's food. Try to count that and make that part of the report, because then we could see, well, he's eating the same amount or she's eating the same amount, but they're not gaining weight. They're not maintaining weight. Something else must be off. Is it the quality of nutrients? Are they being fed the right things? Do we need to shift the calorie density of that meal? Those types of things need to be. Or another one is the supplements. Sometimes you'll see them be supplemented with Ensure, right? Simply because the physical and the mechanical diet isn't working out. We got to make sure that liquid diets become a little bit more supplementary to the diet plan. And finally, incontinence. We talked about it early on. Involuntary muscles, involuntary stomach control. Incontinence is going to be a possible complication of CP. Bladder control. These are all things that you can sense and urge, right? Sometimes you're driving home and they make you want to hurry up and speed through traffic and then run through the house and never say hi to the kids, go straight to the bathroom. Luckily, you have that, as painful as it can be. But poor control of the muscles, keep the bladder closed. Sometimes incontinence can happen because of medication, right? To tone down the muscle spasticity, the medication will actually dull the rest of the senses and the muscle control. So the medical treatments for incontinence include special exercises, biofeedback, prescription drugs, surgery, or surgically implanted devices to replace or aid in muscles. Those are all treatments that, as caregivers, you would have to enact just precautions for if those treatments are available to them. And if you have any questions regarding those, definitely reach out to the healthcare team that set up the issue. But you can also reach out to us here at CareNeed. We'd be able to go and look into that, research it for you, and help develop a training module for you to understand. Okay, guys, that's it for me in terms of this program for CP. Thank you so much. I want to say that in this time, you guys going out there, dedicating our lives to healthcare is a specific thing. It requires a certain talent, a certain level of guts. While society seems to be on fire, we're the ones running towards the blaze. So thank you so much for what you guys do. Thank you for your participation in companies like this, in roles like this.